Hello everyone, I am Dr. Sayan Banerjee, and from today onwards I am starting a Rhinology chapter discussion series based on some previous year questions, concept based teaching, as well as the tentative clinical based vertical integrated MCQs of new pattern of NEET PG and INICET exams. So all the PG aspirants, buckle up. From today onwards, each chapter will start with a MCQ, obviously a clinical one, and you will have to guess the chapter or the topic name from the question. So without any further delay, let's dive in. So this is our first question, wherein we have a female patient presenting with nasal obstruction, nasal discharge and loss of smell. On examination there is foul smelling nasal discharge and yellowish green crusts in the nasal cavity, and the patient is also found to have merciful anosmia. So obviously you will have a image accompanying over here, correct? So in this image, what are you seeing? There is a greenish discharge with crusts, and normally on anterior rhinoscopy we see some bulges like this on the lateral wall of the nose. They are nothing but the inferior and middle turbinates. Mostly inferior turbinates are seen. Okay, now these turbinates are actually absent or rather degenerated in this patient. So obviously something has happened to these turbinates. No, what has happened? Nothing but the atrophy of turbinates. Atrophy of turbinates. So obviously today's topic of discussion or the chapter is nothing but your atrophic rhinitis. If there is no turbinates, they have got atrophied, the patient will have a roomy widened nasal cavity, isn't it? So obviously our answer for this question should be the first option, that is your roomy nasal cavity. So this is the finding which can also be seen during the examination of her nose, correct? But why not the other options? You have to rule them out, yes, correct? So why? Firstly, in nasal polyps there is nasal discharge or nasal obstruction, but this nasal discharge is mostly not foul smelling. Firstly, that means the patient will only have foul smelling nasal discharge in nasal polyposis only and only if this is having a secondary bacterial or fungal infections. Secondly, the patient may also have nasal obstruction but no crusts, and lastly there is no merciful anosmia in nasal polyps, correct? Next, third option says inferior turbinate hypertrophy, ruled out. Obviously there is atrophy of the turbinates, so ruled out. Next, foreign body. In cases of foreign body, what happens? There is nasal obstruction as well as nasal discharge, maybe even foul smelling one, but no crusts and even no merciful anosmia. So there is no merciful anosmia as well. In these conditions of atrophic rhinitis, it is mostly bilateral. It is mostly bilateral involvement, correct? But in foreign body impaction, it is mostly unilateral nasal obstruction as well as nasal discharge, correct? Okay, so that is important in differentiating the foreign body impaction from atrophic rhinitis. So now we have known that topic for today's discussion, and we will start deep diving into the topic with some very important concepts for your PG entrance exams. Without any further delay, let's jump in. So, firstly, definition. In the definition part, it is the chronic inflammation of nasal cavity. Obviously, this is a rhinitis. Now, what happens? Resulting in first keyword atrophy, correct, of mucosal atrophy or turbinate atrophy. Secondly, as there is atrophied turbinates, there is epithelial loss, means the ciliated columnar epithelium, that is the respiratory epithelium with goblet cells, is gradually being replaced with the stratified squamous epithelium. This is known as squamous metaplasia. This is the second keyword you have to find out in the questions, correct? Next, what happens? There is decreased goblet cells, there will be stagnant, viscid, scanty nasal discharge. So that is the third keyword: scanty, thick, sticky, viscid nasal discharge. Now this discharge gradually hardens to form crust. Very important. Now these crusts, what they do? Causing nasal discomfort and obstruction, correct? And all these things occur because of two most important keywords you have to remember: periarterial fibrosis and end arteritis. So if you count, I think there are 5 keywords, rather 6 keywords in this slide. So you have to remember these keywords. You don't have to read whole of the question thoroughly. You have to read, but you have to search, you have to look out for those keywords in that whole paragraph. Otherwise you will need about 30 to 40 minutes to crack one question, correct? That is not possible in entrance exams, right? So you have to look for those keywords, important. Now coming to the next slide, which discusses about the types of this atrophic rhinitis, correct? So firstly, primary atrophic rhinitis, it is the most common variant and most common cause is idiopathic. So idiopathic cause means it is having most of the causes, mostly the causes are unknown, correct? Now coming to the secondary causes. Secondary type of atrophic rhinitis is because of some causes which can be identified, like long-standing purulent sinusitis, like chronic granulomatous diseases like tuberculosis, syphilis, leprosy, rhinoscleroma, like in case patients with DNS, where atrophy occurs in the wider nasal cavity. Whereas it can also be iatrogenic, means we make them. How? Firstly, during functional endoscopic sinus surgery. Obviously, we are removing the ethmoids, we are removing sometimes the concha bullosa. Because of that, some turbinates part are being cut out. Along with that, sometimes we go on and do a turbinoplasty and your radical turbinectomy procedures mainly. Although radical turbinectomy leads to these kinds of atrophic rhinitis mostly, but turbinoplasty and conservative turbinectomy does not, because they only shrink. They are actually planned to shrink the size of that turbinate only to reduce the actually the nasal obstruction for that patient, correct? But the radical turbinectomy is done when the turbinates are being infiltrated with the sinonasal CA. correct? So that is the point when we actually go on and do a radical intervenectomy. Next, during maxillectomy procedures and following some radiotherapy, correct, obviously. So these are the points when there are secondary atrophic rhinitis. Now coming to the forms of rhinitis, atrophic rhinitis. So firstly, it is the rhinitis sicca. It is the milder form and it is involving the anterior one-third of nose only. Very importantly, anterior one-third of nose is only involved. So there is squamous metaplasia, there is obviously atrophy in the ceromucinous glands in the anterior one-third of nose only, and it is most common in workers of hot, dry and dusty weather like bakers, ironsmiths and goldsmiths. So it is also known as the disease of or atrophic rhinitis of deserts, correct, obviously. So you know now at this moment rhinitis sicca is most common in hot, dry and dusty weathers. Coming to the point of ogena. So what is ogena? It is the severe form. So you have to remember that every ogena is nothing but is equal to atrophic rhinitis, but every atrophic rhinitis is not ogena, correct? Because ogena is the severe form of atrophic rhinitis. So what happens in ogena? What is the difference with the milder form? Again, here occurs terminated atrophy, squamous metaplasia, degeneration of goblet cells. These are same, but yes, secondary growth of saprophytes. This is the thing which complicates the disease, and the most common saprophytic infection involving is Klebsiella ogeni, correct? Klebsiella ogeni. You have to remember this. Next, coming to the point of etiology of atrophic rhinitis. You know at this moment the secondary causes of atrophic rhinitis. I have discussed them. Next, coming to primary causes. I have said you already that most importantly this primary atrophic rhinitis is what? Mostly idiopathic in nature, but some causes have actually been identified. So what are those causes? Firstly, they have to be remembered with the mnemonic hernia. So that is the first one. H for hereditary. Most common hereditary pattern known, autosomal dominant. You have to remember this much. Autosomal recessive is also seen, but autosomal dominant is most common. Second cause, E, that is endocrine cause. Most common cause is estrogen progesterone imbalance, and most common thing to occur, yes, estrogen level is getting decreased. Estrogen level is getting decreased. So decreased estrogen level predisposes to atrophic rhinitis. It is more common in thus females after puberty, and thus it should decrease after menopause, correct? Okay, now coming to the next point, R. What is that? Race. So yes, white and yellow races are much more common to develop atrophic rhinitis than Negroes. Next, N for nutritional causes. Nutritional cause, obviously malnutrition, mostly chronic iron deficiency anemia and vitamin A and D deficiencies. I, infection, correct? Which infection? I have said Klebsiella ogeni is the most common infection to occur. A, autoimmune. So obviously autoimmune destruction of the nasal mucosa triggered by any kind of altered cellular immunity and loss of tolerance to the nasal tissue, correct, is actually because of autoimmune disease. Okay, done. These are the etiology. And one more bonus point over here you need to know, that is blood group O much more predisposing to develop atrophic rhinitis. Next, coming to the pathophysiology, we have already discussed it, correct? So just to write down the keywords, what are they? First, periarteritis, and rather to say you, it is not periarteritis properly, it is periarterial fibrosis and end arteritis, correct? This will have lead to decreased vascular supply to the turbinates. This will in turn lead to squamous metaplasia. That means the ciliated columnar epithelium is getting replaced with stratified squamous epithelium. Okay, obviously along with that the goblet cells are lost, so goblet cells decreased. Now if goblet cells are decreased, what will happen next? There will be stagnant thick viscid nasal secretion. This will in turn lead to increased growth of saprophytic organisms, and that will lead to nothing but the atrophic rhinitis. So saprophytic organisms, correct? Okay, so there is atrophic rhinitis, and that is actually terminate side is getting strength. Okay, now coming to the point of clinical features, I have already said onset is after puberty, 14 to 16 years, more common in females, rare in Negroes, that means more common in white and yellow races. Patient will come to us with what will be the symptoms. I have already said in the first question itself. What are they? Nasal obstruction, crusting, anosmia, foul smelling nasal discharge or fetor. Patient may also complain of headache. Sometimes patient may also complain of epistaxis. Most common is after crust removal. Obviously patient is trying to remove the crusts on her own and there is bleeding. This is the most common cause of bleeding up from the nose, correct? Okay, now what is known as merciful anosmia? Sir, the patient is having an anosmia. Firstly, there is no smell from the patient side, but the relatives are going away from her because of foul smelling nasal discharge. So this is a blessing in disguise that the patient is not smelling her foul smelling nasal discharge. That is why this is a mercy from the God for her, and that is why it is known as merciful anosmia, correct? So merciful anosmia is only and only seen in these patients, correct? Okay, on examination there are crusts, greenish discoloration, roomy nasal cavity, atrophied turbinates obviously, and on posterior anoscopy everything seen and normal. Pus in the middle meatus can be seen if and only if there is secondary bacterial infections, correct? Now in this picture you see there is greenish discharge with crusts. Along with that there is terminate atrophy. Along with that there is a roomy nasal cavity, correct? Okay, here in this picture also there are crusts. So this is first one, this is second, this is third. Obviously there are atrophy terminates, and there is a roomy nasal cavity. Correct? Okay. Now coming to the next slide. Why is there anosmia or nasal obstruction? To know this point, we need to go deeper into the nasal physiology. During inspiration, there is lamellar flow of the air currents. No problem. Air is going inside in parallel lines. Obviously, no doubt till now. But during expiration, something occurs. What happens? During expiration, there is the currents, air currents are going like this from inside to outside. This is the most, no problem. But now there are something like these terminates as well as nasal valves. What happens? What are they doing? These air currents, while moving from inside to outside, they are getting resistance from these terminates as well as from the nasal valves. So some portions of these air currents are getting reflected off those terminates and going like this towards the inside. They are known as your eddy currents. They are known as eddy currents. So they are formed during expiration due to resistance from the terminates and nasal valves. Correct? Okay. What is the use of them? What they do? They are carrying the olfactory stimulus from outside to inside towards the olfactory mucosa near the superior meatus. Obviously, they are carrying olfactory stimuli to the olfactory receptors of the nose, allowing us to smell. So obviously, they will cause or they will help in first olfaction. Second point, they have also got one more role to do. They are helpful in aeration of sinuses. Aeration of sinuses. So when these eddy currents are actually helpful for olfaction as well as sinus aeration. Correct? Obviously, the left of air from during the expiration is going inside the sinuses and going to aerate them. Okay? Now, thus coming to the point of causes of anosmia and nasal obstruction. One of the most important causes of anosmia. Why? There are no terminates. There are no terminates, or they have got degenerated. What will happen to the eddy currents? They will not be formed. If the eddy currents are not being formed, olfaction will be hampered. So there is lack of eddy current formation in roomy nasal cavity. This is one of the most important causes of anosmia. Secondly, again, there is loss of olfactory neural elements. There is thick secretions and crusts over the olfactory area. So all these things are there. As well, there is degeneration of secretory glands. You know already, correct? Okay. So secretory glands, if getting degenerated, what happens? There is scanty mucus, and that very much scanty mucus is not sufficient to dissolve odoriferous materials. So that is why odoriferous materials are not being dissolved in proper amount to have olfaction. Correct? Next, coming to the point of nasal obstruction. Again, eddy currents. What they do? The second important role, aeration of sinuses. So there is aeration of sinuses hampered. So obviously there will be nasal obstruction. Correct? Okay. Now, the blunting of sensory nerve endings and crust formation is also important causes of nasal obstruction, and rather this crust formation is the most common cause of nasal obstruction in atrophic rhinitis. You have to remember this. Correct? Okay. This is an MCQ. Now coming to the next slide, which discusses about the radiology of these atrophic rhinitis patients. What happens? You see, in this radiology, in x-rays and in CT scans, you can well visualize that these sinuses walls have got thickened. So there is first keyword, mucoperiosteal thickening of sinuses walls. Correct? Second, there is sinus size is itself decreased. So which sinus? Mostly maxillary sinus. So there is hypoplasia of maxillary sinuses. Second keyword. Thirdly, there is what happens? You see, because the sinuses have got atrophied, and as well there is the thickening of the bony walls of these sinuses, what happens? The nasal cavity is roomy now. There is erosion and bowing of this lateral nasal wall. So you see there is bowing of the lateral nasal walls, correct? So bowing of lateral nasal walls. Next, obviously there is atrophic turbinates, there is roomy nasal cavity, everything seen. But can you properly visualize the INICET process as well as the bulla ethmoidalis? I think no. So yes, again, most importantly, there is a resorption of bulla ethmoidalis and INICET process. Correct? Okay. Now, as the patient is having a thick and bony sinus wall, so what happens? Thickening of sinus walls and mucoperiosteal thickening. If we go on and do a enteral puncture for this patient, that will be difficult. Correct? Okay. Now coming to other investigations. In the point of the other investigations, you know, firstly, hematological investigations. This is an infection. This is an infection. So, of course, there will be increased ESR levels. Even the blood sugar may be raised because it is common in diabetics. Next, hormonal levels has to be checked. Okay. Female patient, estrogen will be decreased. I have said you already. Most common finding to have hormonal on tests, and that is decreased estrogen levels. Okay. Now, if the patient is having a malnutrition, obviously I have said 3 malnutrition: iron, A, D. So yes, serum iron, vitamin A, vitamin D, as well as some protein levels may be deficient. Coming to the pathology, we will go on and do a scrap biopsy or nasal swab smear, and on histopathological examination there will be squamous metaplasia, chronic inflammatory infiltrates, glandular atrophy. No doubts in that. Okay, no doubt. Okay, so chronic inflammatory infiltrate will be mostly lymphocytic infiltrates as well neutrophilic infiltrates. Correct? Okay. Eosinophilic infiltrates are seen in allergic rhinitis, not in atrophic rhinitis. You have to remember this point also. Coming to the special tests. Obviously, the patient is having a nasal obstruction. Eustachian tube will be functionally non-patent. So, on saccharine test, there will be increased or prolonged mucociliary clearance time. Culture sensitivity of nasal discharge to detect any secondary infection. Correct? Okay. Maybe done. Next, DD. Differential diagnosis. You know already. There is dry nose, there is angina. For dry nose, it can be rhinitis sicca, it can be atrophic rhinitis, it can be radiotherapy, it can be Sjogren's syndrome. Angina, atrophic rhinitis, purulent sinusitis, rhinitis caseosa, as well as nasal foreign body and malignancy. I have already said in nasal foreign body, but also in malignancy, there is unilateral nasal obstruction and discharge. Other DD, any chronic granulomatous disease, like in cases of syphilis, lupus, leprosy, tuberculosis, rhinoscleroma, sinusitis, everything. In syphilis, you have to remember, there is not only crusting, there is not only foul smelling nasal discharge, there is not only dry nose. Along with all those findings, there will be nasal synechiae and septal perforations. These have to be given as keywords in the question. Correct? Okay. Next, coming to the point of treatment of this very condition of atrophic rhinitis. Mainly, firstly, the medical management. Most important treatment of medical management is what you know already: alkaline nasal douching. And in alkaline nasal douching, what do we do? BBC. What is BBC? Firstly, sodium bicarbonate. Second B, sodium biborate. Third C, sodium chloride. So these three things needed to be dissolved in 280 ml of sterile water in 1:1:2 ratio. So sodium biborate and bicarbonate are in 1 portions each and 2 portions of sodium chloride, correct? Okay, so there is sodium bicarbonate, sodium biborate, sodium chloride, ratio 1:1:2, 280 ml of sterile water 5 to 6 times a day. What are their uses? Sodium chloride makes the solution isotonic, important. Sodium bicarbonate helps to loosen up the crusts, and sodium biborate acts as an antibiotic. Correct? Done. Coming to the point of next target, we are going to replenish the nasal secretions to decrease the dry nose. Correct? How to increase the nasal secretion? We may use potassium iodide that will promote and liquefy the nasal secretions. We may use Mendel's nasal paint that is having estrogen or estradiol in oil of sesame, which is also promoting the nasal secretions. Correct? Okay, done. So alkaline nasal douching, potassium iodide, and Mendel's nasal paint. These are helpful. Okay, next. BBC we have discussed. Coming to the point of next target, and that is increased vascularity. Why is there decreased vascularity? Because there is decreased estrogen. We have to supplement estrogen levels. How? With prostigmine, neostigmine spray, with estradiol spray, or with stilbestrol tablets. Correct? Otherwise, we may also go on and give something which may have estrogen or which may convert into estrogen, like in placental extract or nicotinic acid. Correct? Okay, we will be discussing about the placental extract in recent advance in the next slide. Before that, we may also go on and use something to decrease the foul smelling from the nasal discharge, that is to decrease the fetor. What is the use? Antibiotics like streptomycin, 1 gram per day for 10 days. It will decrease crusting as well as fetor. We may also go on and do some sprays or painting with chemicetin antiogena solution, correct, which contains, what does it contain? It contains COPD. What is COPD now? C for chloram phenyl oblique chloromycetin, O for estradiol, P for propylene glycol, D for D2. You have to remember this is vitamin D2, correct? So yes, the chloramphenicol, chloromycetin, estradiol, vitamin D2, propylene glycol, these are the contents. So that is about the COPD. You have to remember in chemicetin antiogena solution. Next, 25% anhydrous glucose can also be used in glycerin. How does it help? The glucose helps in inhibiting the proteolytic saprophytic organisms, and glycerin acts as an hygroscopic agent. Correct? Okay. Now coming to the supportive management. If the patient is having hormonal deficiencies, correct them. If the patient is having malnutrition, correct them. Iron deficiency, correct. Vitamin A, D, everything has to be corrected. Okay. Now coming to the point of recent advance, and that is placental extract in atrophic rhinitis. Placenta is having progesterone, estrogen, biogenic stimulator, antibodies. So how does it happen? Firstly, progesterone. Progesterone leads to hyperplasia of nasal mucosa and glandular secretions. Estrogen leads to vasodilation and promoting the vascularity. Obviously, what is the help of that estrogen? Obviously, vasodilation. Biogenic stimulator, metabolic and regenerative process. Next, intraplacental serum boosts up immunity because of those antibodies, and mechanical narrowing of the nasal passage is also being fulfilled by this placental extract. So this is all arounder. Okay, this will increase the nasal mucosal proliferation as well as glandular secretion, as well it will help in vasodilation and vascular supply to the turbinates, and it will also increase the metabolic and regenerative processes by means of biogenic stimulators. As well, it will actually boost up the immunity and mechanical narrowing of nasal passage. Okay, done. Next comes up with surgical management, And in surgical management, we have some aims of surgeries, like we may have to decrease the trauma of air turbulence. To decrease the trauma of air turbulence, we have nasal closure and volume reduction operations, where we have in nasal closure procedures, we have Young's procedure and modified Young's procedure, Young's procedure and modified Young's procedure. These are very much important. Secondly, there is the increased nasal secretions by means of parotid duct implantation into the maxillary sinus mucosa, known as the Witt-Max operation, wherein we go and do a stensions duct or parotid duct implantation into the maxillary sinus mucosa, which will actually redirect the salivary flow into the sinuses and will increase the nasal secretions. So this is known as salivary irrigation procedure. Next, to increase the vascularity of nasal mucosa, we may go on and do a denervation procedure known as STAMI's operation, wherein we go on and do a cervical sympathectomy, stellate ganglion block or sphenopalatine ganglion block. Next, we may also go on and do a nasal implantation of maxillary sinus mucosa. Okay, no doubt. Now, volume reduction operations include Lawton-Slager-Wilson, sublevel implants and vestibuloplasty. You have to know about Lawton-Slager and Wilson for your MCQs. Coming to the surgical management proper, we have mainly the Young's operation as well as the modified Young's operation. Young's operation, it was invented by Young obviously in 1967, where one nostril was actually completely blocked, completely closed by raising two circumferential flaps, inner mucosal flap, outer cutaneous flaps. So what happens? We will actually suture them in midline with no gaps. What happens? Obviously, we will not close the bilateral nostrils like that, otherwise the patient will be killed. Okay, isn't it? So here, first of point, bilateral nostrils simultaneously cannot be done. Correct? And here it is reopened later after varying periods ranging from 6 months to 1 year. Then the other nostril is done. Whereas in modified Young's operation, it is similar to Young's, but the anterior nares are partially closed. Partially closed means there is a 3 millimeter gap in the anterior nares on both the sides, and here we can do the bilateral nostril closure simultaneously, isn't it? This is good. And here recanalization is done after 12 to 18 months with a tri-radiate Mercedes-Benz incision. So how is it being shown? You see, this is the Mercedes-Benz incision which is being placed. Correct? So what is the use or what is the advantage of this modified Young's operation then? Firstly, as there is a 3 millimeter gap, patient can breathe. So obviously nasal breathing is preserved. Secondly, there is no complaints of denasal voice and better cosmetic result. Okay, but we can actually progress and monitor the stages of development of those turbinates and nasal mucosa, everything within the nose, with a 2.7 millimeter nasal endoscope through that 3 millimeter gap. Correct? And even glucose in glycerin drops can be instilled. Both nostrils can be operated in one sitting. I have already said that. Okay, done. Now coming to other operations, there are some other operations. You don't have to remember all those things, only 3 things you need to know, these 3. Firstly, Witt-Max operation, I have said already. Stensen's duct implantation into maxillary antrum, redirect salivary flow into the sinus. This is a salivary irrigation procedure. Secondly, Lawton-Slager surgery, wherein the lateral wall of the nose is medialized to narrow the nasal cavity. It will reduce the nasal cavity volume and facilitates periodic nasal irrigation again. And Wilson's operation, submucosal injection of Teflon paste. It also reduces the nasal cavity volume and used for structural support or augmentation. You just I have also said you about STAMI's operation, although sympathectomy involving stellate ganglion or cervical chain block. I have said you, and this will actually target the automatic regulation for the nasal conditions. And sublabial implantation, I have also said that implantation of materials like bone, cartilage, fat, placental beads, hydroxyapatite fibrin paste, plastipore, acrylic paste, silastic. These three operations have been asked in your question apart from those two, Young's and modified Young's. Although, but these are also very much simple things to do. Okay, Raghav Sarans have not been asked any time, but just for completion, this operation is actually involves implantation of maxillary sinus mucosa in nostril through intranasal antrostomy, which I had said in the part of this increasing the vascularity of nasal mucosa, nasal implantation of maxillary sinus mucosa. This is known as Raghav Sarans operation. Correct? Okay. Now, coming to the point of these MCQs now. So the first question says, surgery where nostrils are partially or completely occluded is done for which condition? Very much simple question. Atrophic rhinitis, no doubt in that. If completely closed, Young's procedure. Sorry. And if partially closed, it is known as modified Young's procedure. Second question, cause of nasal obstruction in atrophic rhinitis. Actually, the third and fourth question are same. Most common cause of obstruction in atrophic rhinitis is, okay, options are excessive formation of crust, crusting, both are same. This is the answer actually, you know already. Polyps, no. Secretions, no. DNS, no. Synechiae, no. Synechiae seen in syphilis. Hypertrophy of turbinates, obviously not. That is the atrophic rhinitis. So the answer here is excessive formation of crust or crusting. Correct? Okay. Next, all are true regarding atrophic rhinitis except crusts are seen, obviously seen. Anosmia is noticed, seen. Young's operation useful, yes. More common in females, not in males. So that is the answer. Next question, which of the following cannot result in atrophic rhinitis? Klebsiella-Lowry obviously can result in. Empty nose syndrome, there is empty nose, isn't it? There is empty nose. There is no confusion regarding empty nose syndrome. Next, granulomatous conditions, I have said you, TB, syphilis, anything, leprosy, rhinoscleroma, everything can lead to atrophic rhinitis. Okay, so nasal polyps can actually not result in atrophic rhinitis. Now, some tentative questions which can be asked. So, which of the following best describes the primary vascular pathology that initiates the atrophic process in atrophic rhinitis? Vasodilatation and hyperemic decalcification of turbinates. Vasodilatation? Sir, there is vasoconstriction, there is decreased vascular supply. So, obviously wrong. Next, formation of new fragile capillaries, wrong. Hyperplasia of nasal mucosal glands, there is atrophy, wrong. Periarterial fibrosis and endarteritis, so this is the correct option, correct? Okay. Next, a patient with atrophic rhinitis has a wide roomy nasal cavity but complains of nasal obstruction. What is the physiological reason for this paradoxical sensation? Allergic inflammation of mucosal swelling, allergic rhinitis, not in atrophic rhinitis. Severe hypertrophy of nasal turbinates, atrophy occurs, not hypertrophy. Lack of eddy current formation in roomy cavity, correct. Correct? Okay. Excessive production of thick viscid mucus, there is scanty viscid mucus, not excessive production. So there is lack of eddy current formation in roomy cavity. That is the answer. Correct? Okay. Next question. What is the characteristic cellular change observed in the nasal epithelium of a patient with atrophic rhinitis? There is squamous metaplasia. You have to remember that. What does this mean? Ciliated columnar epithelium getting transformed into stratified squamous epithelium. So here the options are atrophy of squamous epithelium into ciliated columnar epithelium. Just the opposite. Wrong. Metaplasia of ciliated columnar to squamous. Correct. Hypertrophy and increased activity of goblet cells. There is decreased goblet cells. Wrong. Infiltration of nasal mucosa by eosinophils. Allergic rhinitis. I had said you. Remember, there is lymphocytic as well as neutrophilic infiltration, not eosinophilic infiltrations. So the answer here is B. Correct? Next question. A 20-year-old female presents to the outpatient department with complaints of nasal obstruction and anosmia. She expresses distress over the fact that her relatives frequently comment on a foul odor emanating from her surroundings and tend to avoid her. So what happens? She is having anosmia and your obstruction, nasal obstruction, but there is a foul odor emanating from her surroundings and relatives tend to avoid her. That is merciful anosmia. What is the most likely cause for her condition? Blunting of sensory nerve endings in the nasal cavity. Sir, lack of sensory neural tissue is actually in the thing, not blunting. Blunting of sensory nerve endings lead to nasal obstruction, not anosmia. Next, loss of, so this is wrong, loss of olfactory neural elements, yes, and gland degeneration, correct. Lack of id current formation during expiration, correct. So the answer should be both B and C, both B and C. Okay, next question. This is a tentative clinical based question, vertically integrated. Now solve it. First question, a 35-year-old female comes to OPD with the complaint of nasal obstruction. So there is first one, female. 35-year-old means after puberty, before menopause. Now complaining of nasal obstruction. So first point is nasal obstruction now for past 6 months. There is complaining of excessive crusting in the nose. There is now very foul smell emanating from her nose of the patient. Okay, these are the crusts, nothing more than that. Okay, now what happens? The endoscopic appearance of the nostril is given below. She also complains of lethargy and occasional breathlessness. Okay, now she attributes to her, which attributes to her nasal obstruction. There is no history of any nasal surgery or trauma. Okay, so true about this patient is options. Firstly, she should be investigated for granulomatous conditions. Atrophic rhinitis, we may have got investigations for granulomatous conditions. Next point, the nose should be cleaned by solution of sodium chloride, sodium bicarbonate and glucose in distilled water in the ratio of 2:1:1. Obviously, correct. This is a case of empty nose syndrome. No. Nasal steroid spray should be started. No. Correct? Okay. Now, so the answer should be B. Just read the option carefully. This is the thing which you miss. What? First, you just check out the options. What is being shown over there? The patient is nose should be cleaned by sodium chloride, okay, sodium bicarbonate and glucose. Is it glucose? This should be BBC, not BGC, and this B is biborate. Correct, isn't it? So this is never ever going to be glucose in this alkaline nasal dosing. So this is a wrong option to deal with. Now the answer should be, it should be investigated for granulomatous conditions. I have said you that granulomatous conditions may lead to this thing. Now there is also one clue in this question which you have missed, as because I have shown you those points. What? See, she also complains of lethargy and occasional breathlessness. So these two findings are actually representing a systemic disease like TB, like sarcoidosis, like anything, any chronic granulomatous disease, like scleroderma, isn't it? So that will lead to your atrophic rhinitis. So never ever rush for your answers. One single mistake will lead to a negative marking. Please. So this is the point you have to remember. No, glucose is never used in alkaline nasal dosing. Next question. Now the patient is presenting to you with nasal obstruction, anosmia. Her nasal endoscopy picture is given below. So what does it show? Again, the crusts. All of the following constitute the treatment except, you know already, na? Nasal dosing, yes. Infrared turbinectomy, never ever. Young's operation, yes. Glucose and glycerin, yes. So this is your inferior turbinectomy is the answer of choice. Next question, a serology test is for syphilis, that is VDRL. It would be ordered for a patient with the symptoms of atrophic rhinitis primarily to rule out specific infectious cause of secondary atrophic rhinitis. Yes, syphilis can lead to secondary atrophic rhinitis. This is correct option. Measure the levels of serum iron and vitamin A. Assess patient's overall immunological status. Correct, partially, but not here. And determine patient's blood group. Never ever. So obviously the answer should be rule out specific infectious causes of secondary atrophic rhinitis. So now we have with us the point of summary, that is the key words which need to be focused in the chapter of atrophic rhinitis in your question. Whenever a clinical question comes to you, you have to think like the examiner and answer smarter with the help of these keywords. You have to look out for these keywords, correct? What are the keywords then? First keyword, atrophy. Anything hypertrophy, ruled out. Second keyword, foul smelling nasal discharge. In short, bitter. Third, thick, yellowish green nasal secretion. Fourth, crusts. Fifth, squamous metaplasia. Sixth, goblet cells decreased. Seventh, what happens? Why all these things are happening? I had said you to remember two keywords: peri-arterial and enteritis. Next, BBC. You have to remember in alkaline nasal douching. Then COPD, that is in chemicetin anti-ogenous solution. Tenth, potassium iodide and Mandel's nasal paint. Young's versus modified Young's operation. Next, three operations: Whitmax, Wilson, Lautenschlager. Correct? These you have to remember. And obviously one more thing, eddy current, lack of which is responsible for both nasal obstruction as well as anosmia. So this is how you will summarize each chapter to identify the keywords which you need to know. Okay, one more thing you need to know: females after puberty. And one more thing, decreased estrogen levels. So that's all. Thank you very much for your patient listening. Today we have dealt with the chapter of atrophic rhinitis with the help of some previous year questions and some tentative NEET PG or INICET based new pattern questions. Now I think this will help you in your preparation, although there are many things left which will be actually taught in your PG. That means if you get your PG shift in ENT. Otherwise, for now, most of the concepts which will be needed for your MCQ entrance exams from this chapter have been dealt today. Obviously, the comment section is open. You just drop your questions, if any, from this chapter, and stay tuned. Subscribe me for further updates regarding the next chapters and their discussions in a similar way. Thank you.